So let's turn to Dr. John Golfinos, Chairman of Neurosurgery at NYU. So, Dr. Golfinos, how is VR more than just pretty pictures? How does it really impact the patients?
Well, so that was, I was trained by Patrick Kelly, and Patrick would look at some of these things and say, well, that's just pretty pictures. How's it really going to help us? And that's the difference. This is real virtual reality. This is really rehearsing a case before you get to do it. So I'll show you a difficult case. I always don't like when people show you a new technology and they show you some trivial case like a convexity meningioma and say that it really helped them. This is a much more complicated case. And this is a middle-aged gentleman, and I got the goggles on now, so you should be able to see the MRI behind me. And he's got a posterior thalamic cavernoma, which you should see right on the screen. And the issue was that he went around, he had the means to go around to several places, he got several different opinions, and out of those you can see the lesion right here, right? And out of those different opinions then, he came to us. And so Howard Rena, actually, who saw the patient, said, John, if you can just get me there, I can take it out. And I said, Howard, I'm going to get you there. So we actually looked at the different trajectories that have been proposed at other institutions and some very well-known places, and people wanted to come in with lateral trajectories. But the problem you can see is in blue, the corticospinal tract, and then also inferiorly, the optic radiations. And those are going to be critical for us, and that's what we wanted to see. So we ultimately came up with a superior parietal lobule approach, which will be the approach that you'll see next. Using the surgical theater, we're able to actually rehearse this case. So now I've switched you, so we're looking back. We're at the patient's back. This is how we actually positioned the patient in surgery, so they were sitting straight up, so the nose was away from us. But the critical thing is we can see the actual veins that we're going to use, and this allowed us to plan the cortical incision right here, using an elliptical retractor to get us down into the ventricle. And this was the virtual reality, and I'll prove it to you, because here's a video that shows you the reality at the time of surgery. There's that vein, exactly, and we put our incision right where we had seen it in virtual space. Now you're seeing it in real space. So we actually rehearsed the case ahead of time. And it allowed us to look at all those other trajectories and then pick this one as the one we figured was going to be the best. That's the elliptical retractor going in now. As you can see, it'll come up a little closer. Okay, so now here's our corridor, and I'm now flying you right down the corridor, and we're looking for the ventricle, and you see it in front of you. So I can see that my retractor is going to come down, so I see the lateral wall of the ventricle. Here's my virtual pointer, lateral wall of ventricle over here, and choroid plexus was down to my left, so you can see that. And as we look at the video, this is in real, obviously there's a video we've overlaid, the real video of entering into the ventricle. And now as we enter into the ventricle, the question becomes, well, where is the thing? But there's no time to panic now because we've rehearsed all this. We know where it's going to be. We see the choroid plexus down there to the left in the corner over here, and we know that this is the groove between the posterior thalamus and the lateral wall of the ventricle where we're going to enter to find the real lesion. And here's the virtual reality that we used to practice that, and that was the choroid plexus. And the best part is we can ghost the virtual reality to know that the tumor is going to be cavernoma is going to be right here in front of us. So it becomes a situation where I tell my colleague Howard Rena, I got you there, Howard. Now all you have to do is just cut here because we've seen it before in the virtual space. And so now the best part is we can also even go down past it, and we can look back. Once we're past it, we can look back up and see where we came from. And that's the entire approach there you can see. And you can see that finally, so it's really, if we play the video now, you'll see the actual resection, and it's where to cut. And the cut was exactly where we planned it to be. You can see that choroid plexus was down there, and that was where we made the incision here. And then the other thing that's important is that we saw the tracts in front of us. We know that they're away from us, so we were able to avoid both the corticospinal tracts and the optic radiations below us. So it makes a much safer surgery, and that's the actual cavernoma coming out. Howard did a great job on this and pulled it straight out. But the difference is it really enabled us to plan out the different trajectories and see which one was the best one for the patient. And the interesting thing is you had a lot of very well-known institutions looked at this and everyone disagreed. What's the best way to do this? But that makes a big difference to us, being able to actually rehearse that case and rehearse each of the potential trajectories, the lateral versus the superior parietal lobule approach, all the difference in the world for us. So it's a real tool. We use it on every case, and we use it more on the difficult cases than we do on the simple cases, obviously.
John, what other kinds of cases have you used it for?
Skull-based meningiomas, where you're looking to see which arteries are buried in it, especially a clinoidal meninge. You know that the carotid and the optic nerve are going to be medial, but where are they? So it's great when you can actually walk through that and rehearse it and see the arteries. Know where you're going to run into them before you're there in the surgery.
And have you ever used that to explain this to a patient?
Sorry?
Have you ever used that view to explain it to a patient why you're using it?
It's got to be the rare, not rare, but it's got to be the tech-savvy patients. I think, as Warren said, the younger ones are really ready to see this, and you watch them, look at it and get it instantly. And they'll say to you things like, "Wow, that artery really is awfully close, isn't it?" So they get a real appreciation for what we do, I think.
Thanks, Dr. Golfinos. That was great.